reflected from the 1st of March to yesterday or almost yesterday. We have had in the whole country of Catalonia, we have had almost 150,000 positive cases, which is stated positive cases. Probably there have been more people infected which have not taken the test. We have had almost 10,000 people in hospital, of which almost 1,500 have needed intensive care unit assistance, which is a lot of people, so it's a big number. And unfortunately, we have had 13,425 diseased people, which is also a large number, too large. This is only in Catalonia. In whole Spain, the places which have been more impacted are the two biggest cities, of course, because where most of the population is living in the least square meters. So the infection has run quite freely. The situation is not controlled. Nowadays we still have restrictions both in Barcelona and in Madrid. It's not as strict as it was, for example, in March or April, but we're still having quite a lot of restrictions. The organization I work for is the Catalan Medical Emergency System, to which we as a psychologist team, we have been related to this organization since 2006. And we have been working until last March as a team which was activated. So we were not inside the organization itself, but we were an outside team activated every time it was needed. We have been activated almost daily, in a daily basis, these last years. And from March on, we have become members of the medical emergency systems as the psychologist team. This organization has got three different areas, one of which is the medical emergencies outside our hospitals. Then we have the sanitary transportation, which is not urgent, but which is also done by our ambulances. And then we have 061 Salud Respon, which means telephone intervention for emergencies. During this pandemic, we have been working close in these two first areas that I was talking about, in the emergency systems outside hospitals and on the phone intervention. And from the beginning, we have been asking by the commandment of the emergency system to become active members, active workers of the organization, and to try to reach as much people as possible. So our objective was to offer a complete assistance to the people, to the population of Catalonia, both through physical attention assistance and psychological assistance. This has been the intention from the beginning of the pandemic. As I said, and this was an objective set by the commandments of the organization. We started one of the field work that we started with was the support to our co-workers. So the first people who were impacted by the pandemic were the medical staff, were people working in the emergency system. So these people were the first ones to receive our assistance, and it was not only to doctors and nurses, but we also assisted the operator, the emergency staff, everyone involved in the emergency system, which was overloaded, especially during the first weeks. This assistance was done in the place, so we went to the place where in the bases where the ambulances were, where the telephone operators were working. So we were in person from March to June. And we have been covering a timetable between 6 in the morning until 11 in the afternoon, so we could find and meet all the shifts of our co-workers. We were doing either individual intervention when under request, so they had to ask. We were also doing small groups intervention, especially with commandments. The people who were commanding the organization also needed some support, and bigger group interventions, basically psychoeducational. There were 26 psychologists involved in this project. We are a team of more than 70 psychologists in the emergency systems. So we didn't need extra people to work in this project. We were 26 working in this project. And between April and June, we had registered a total of 773 interventions. This was the beginning of the intervention. Then we continued to ambulance staff, so we went outside Barcelona, where the biggest population is, and we went to all the bases with ambulances, staff, and we also supported them through the talk technique protocol, which is a very brief intervention. I will talk a little bit about this later. And we covered 1,521 participants all through Catalonia, all through the area of Catalonia. We had 375 talk groups, and it started in March, right from the beginning, until June, where this intervention was finished, because it was detected it was already not needed. And later on, we got the necessity to work with general population. We decided that it was also especially through the lockout. So these weeks where people stayed at home, couldn't go out to work, couldn't go out and socialize. You know that Spain is a very socializing place, and this has been really difficult here too. So we got the request to work with general population, and the first part of this work, of this intervention with general population, was working peer to peer with doctors and nurses, which were working on the phone in the emergencies. So the emergency system on the phone here has a circuit which is very protocolized, and we have, first of all, the first responder is an operator, a telephone operator, that listens to the first demand and trespasses the call either to the doctor or the nurse. Then in this case, from the beginning, from April, not March, but April, we were included in this team of medical emergency systems, and the operator had either the possibility to direct the call to a doctor, to a nurse, or to a psychologist. So for the first time in history here in Spain, we psychologists have been working peer-to-peer with the medical staff. In this system, 34 psychologists were involved. It has been an extraordinary experience. I myself participated in this experience, and it has been really, really interesting, exciting, tiring too, exhausting, I'd say, because we were working from April to September non-stop. We were doing 12-hour shifts, day in, day out. So we spent 12 hours on the phone listening to people and talking to people, and then 12 hours at home because we were locked out. So we had this dichotomy of working and staying at home because there was a pandemic, and it has been an experience, quite experience. We have done 3,470 registered interventions, And I include here a curious information, which is 72% of the calls were for women or from women, and only 27% were for men or from men, because some of them were from women to men. But this is, we still have all this data, all this information gathered, and we have to, of course, analyze and take conclusions. But this data that I'm presenting here is the beginning of this of the conclusions of what we have been doing. Then we more or less in April we were requested to reach a higher population, so to find a way to reach the highest population as possible. And so we developed an application, a mobile application, which is called gestioemocional.cat. Emotional management would be the translator. And this is an application that was developed in express time, really. So our computer system programs were working speed. And they did this great job of starting this application. And through this application, it was launched, it was advertised on TV, on the radio, it was advertised everywhere. So everybody could reach the application, and there were lots of downloads of this application. It was possible also to use it online. So we had these two areas to reach people. And then the emergency system had to locate 125 psychologists at the time. So they had to organize a bigger place with all the computers, with all the infrastructure that was necessary in less than a week. And we contracted 125 psychologists to work on the demands of this application. The app contains, first of all, contains self-evaluating pages. So you have self-made tests that people can answer questions, so we can screen what kind of affection they have. Most of the population, most of the people who take these tests don't express bigger or huge diagnosis. Most of them have acute stress reactions, which are considered under normal reactions after the situation that they are living. So these people are directed to resources that they can use themselves for emotional management. So they are not contacted by the psychologist because it's considered that they can help themselves through some practical information that they have in the application. This is the interesting part, in my opinion. So we can reach a large number of people without being there. So helping them with techniques and resources that we are sure that can help them. Then when the test screen, when they find somebody who really needs more professionalized, more individual intervention, they can leave their personal information in the application. They can leave their telephone number, basically, or an email, and they are contacted. So everybody that leaves their personal information because he or she is requested to do it because the tests have been considered some kind of risk, then a psychologist contacts because this is still working. And so these 125 psychologists that I was mentioning were the people who were really contacting on the phone this person that had left the information. Here you have some pictures of this place work. Here we have the psychologists with our uniforms. This has been really an honor and something exceptional to us, because, as I said, we have been there working peer-to-peer with the other medical staff, and we have really been very welcomed, and this is the place that was organized later for us. And the numbers really say that we were needed, because we have had more than 300,000 entries, valid entries, because there have been lots of entries which were only, I suppose, looking at what was this, but nobody or didn't answer the test, but valid entries more than 300,000, which is a lot of people. Finally, until last September, till the 30th of September, the psychologists had contacted more than 7,000 people. So these are the people who were detected to have kind of risk and who left their personal information to be contacted, because some of the people, they were the minority, but some people were detected to have risk but didn't want to be contacted, so they didn't leave their information. And of these 7,000 people who were contacted, there was contacted means there was a first phone call. Of these people, 842 who needed follow-ups. Being an emergency system, we were allowed, and it was decided that we could do a maximum of 3 calls to follow up this case. If the psychologist detected that he was, or this person needed more intervention, professional intervention, then this person was asked to contact the public system of health. So the numbers are quite astonishing, as you can see. All the psychologists, besides the psychologists that were part of the emergency system already, the 70 people who have been working in the emergency system since 2006, all the neuropsychologists that were contracted, they were also trained in psychology of emergency. So all of them had taken the training that we have been doing for many years now. And they've also received an express training on the 3 working models that we have been using, which is the basic PH coping strategies model, the 6 C's model, which has been really, really useful, and we are very thankful to Moshe from Israel, and the talk debrief, this technique of debriefing, which takes only 10 minutes, that can be done in the field. And this has been a very useful model also to work with the commandment, because the talk groups were led by the psychologist that was assigned to this group, and the commandment, the commandment of the medical staff. And we worked peer-to-peer also with them, only to talk to the ambulance workers and to detect, first of all, their state, so that they could debrief a little bit what was happening to them in their day-to-day work, and also they had the contact with the commandment of the organization to recognize their work, to ask for necessity. So it was not only psychological intervention with the co-workers, but also an organizational intervention, and it was very brief, but really the impact has been very useful and detected to be very useful. Everybody agreed on this. Our intention is to take brief and simple actions just to build resilience, to help cope strategies building, to reduce vulnerability, and in the end to recover functionality, which is our job as psychologists of emergencies. I'd like to finish with this sentence that a doctor said to me, I think it was around May, so he had been working with us for 2 months, and he was quite reluctant at the beginning to have psychologists working next to him, but finally he said to me, psychologists are here to stay. And I hope this was not only a hope, but a reality. It's still a reality. We are still working, not in such a huge number of psychologists. We have been reduced to a group of 25, but we are here to stay because we think we are useful, and we've proven we are useful. I've tried to make a big and quick summary of our work, which was huge and bigger than I've been able to explain here, but I hope I have transmitted everything that you needed to know. So thank you for your attention, and again, thank you for the opportunity to explain what we have been doing.
Anna.
Hello.
Okay. Respect. It's amazing to hear of the volume of work that has been done in the service of supporting the medical professionals, and I'm also amazed with the technological innovations that were developed to support this process. Let me see if we have a couple of questions either from the audience here or from the chat or the Zoom.
We have a question here. Do you think the rest of Spain will take up this way of working?